Good morning and welcome to our monthly live broadcast of peripheral intervention cases from Mount Sinai Hospital here in New York City. I'm your host for the day, Vishal Kapoor. Today we're going to present a very different but very interesting case in the cath lab with PK and in collaboration with our interventional radiologist. Also, as a moderator, it's my pleasure to have Dr. Srini Tamala, who's joining us remotely from Florida. He's actually traveling, but somewhere between Florida and New York. He's right there. Good morning, Srini. He's the Director for Vascular Services, Florida Vascular Specialist. He's also the Chair of CLI Global Society Education Committee, and he's a voluntary assistant professor at Miami Health System. So it's a pleasure to have Srini as ever. We love him in person, but remote, we'll take it this time. All right, so before we go to the lab, just a few home chores. I'm sure you know about our annual New York Endovascular Summit, which is scheduled this year on between September 22nd and 24th. A nice, comprehensive, still having a lot of fun, educational conference, which is dedicated more to endovascular, aortic, and venous component, with some addition of fellows courses and podiatry courses added to this fantastic 3-day course in September. So please, the agenda and the other tasks will be uploaded soon, but please keep yourself posted on nyevs.org for all the detailed information which should be coming up. And before I take you to the lab, as you know, we've been training fellows for almost 11 years. So any of you who's watching, any of their fellows who might be recently graduating from any of the interventional fellowships, or somebody who's recently graduated and is interested in doing a dedicated 1 year of comprehensive fellowship, we train here 2 endovascular fellows every year, going up to 3 hopefully this year. So we'll be more than happy to accept the applications. The application is also on the Sky Journal Career website. So please feel free to email me, my first name vishal.kapoor@mountsinai.org, and we'll be happy to talk more. So without further ado, good morning, Srini, and good morning, PK.
Good morning. Good morning. That was a great introduction. It's my real pleasure to welcome Rahul Patel, who's really needs no introduction. He's been a colleague of ours for the last 10 plus years in IR. And, you know, when we have difficult cases, as we all know, we love to collaborate with our colleagues, be it vascular surgery or IR or vascular medicine. Rahul, thank you so much for taking time and coming.
Thanks for having me.
And behind Rahul is Ray Lascano, our interventional nurse practitioner. In front of me is Osman Jaffer, our graduating fellow. He's going to be up in Connecticut this year, so you guys will see him, you know, up in Connecticut. And Marichu, our lead nurse for endovascular, and our lead tech, Damien, is back from vacation, so very happy to see him. So we have a really fantastic case, and you know, I had spoken to Rahul, and Pablo Kim is joining us as well. He's just running a little late. Who's our vascular surgeon here at Sinai. And the reason we decided to do a collaborative case such as this, there's Pablo. Pablo, come on in. The reason we decided to do this case together is because there's been a lot of emails coming to us at our website regarding venous disease. As all of you know, this year we've been having a little bit more of a focus on venous, and I think that it's a good sign to know that people want to learn the right techniques, and so therefore we picked a case which I think is representative in terms of what needs to be done for a difficult situation with IVC filters. So without further ado, as Dr. Kim is getting ready, we're going to go ahead and have our fellow present the case, and then we'll get started with Rahul reviewing with Pablo the CT and everything.
Thank you. So it's a 57-year-old woman. She has hypertension and venous disease with chronic DVT. Extensive history starting from a provoked DVT in the perioperative setting of knee surgery back in 2012. Unclear really if the INR was continuously therapeutic in the initial treatment period. She's essentially now suffering from a post-thrombotic syndrome with left greater and right swelling, redness, pain in the left leg, and a CT Venogram showing some venous outlet obstruction. She's a CEAP 4. In November 2012 is when we first saw her. She had presented to the ER at that point with left knee pain in the post-operative period following knee surgery. Ultrasound showed acute DVT in the left common femoral vein, the femoral, and the POP. She underwent a thrombectomy of the left common femoral vein by a popliteal approach, and an infusion catheter was basically left in place with TPA for 24 hours and DC'd on Coumadin. February 12th, 13, a few months later, she was seen in clinic, therapeutic INR, symptoms have improved, not fully resolved. She came in April at that time for a clearance for contralateral knee surgery. And essentially, ultrasound was repeated, which showed some improvement from the past. There was some deep reflux and essentially chronic DVD at that point. In April, in the perioperative setting of her knee surgery, an IVC filter was placed as her clot had occurred in that setting in the past. And so we went ahead while Coumadin was held. The IVC filter was placed. It was an Optis Cordis IVC filter that was put on April 15th. She was seen once in 2014 and then followed up again in June of 2015, continued on Coumadin, seen in the office. Again, duplex was done. There was some old deep DVT of the common femoral vein, profunda, femoral pop, and gastremus. That was really unchanged from the prior study in 2014. She also had some deep and superficial incompetence as well as in the perforator as well. We lost her to follow-up until about 2019. She came back to the office, was feeling well, wanted to come off the Coumadin. We put her on Xarelto at that point. Followed up again 2021. Again, some left greater than right swelling at that point. A CT Venogram at that point showed no thrombus in the IVC filter. Long segment stenosis extending from the left common femoral vein to the left iliac to the left common with associated calcifications. Unfortunately, she traveled out of the country at that point and then, came back a little bit later, again in April of 2023, and she said, okay, I really want something done. I'm having a lot of symptoms at this point. I'm not going anywhere now. I'll be around. So another CT venogram was done. Her leg was huge at that point. A lot of swelling, a lot of pain. So we did another CT. Her meds are Xarelto and amlodipine. This is our CAT scan that was done in April. You can see the IVC filter is clear down here. I'll show you another picture, but there's pretty extensive compression of a pretty diminutive left common iliac. You can see it in this picture over here with the right common iliac and the left ostial iliac vein. But it was read as a diminutive left common iliac vein with proximal compression into the right common iliac artery consistent with chronic occlusive sequelae of DVT associated with the May-Turner syndrome. She had multiple venous collaterals in the subQ tissue, and they were saying to correlate with signs and symptoms of a post-thrombotic syndrome, which is essentially what she has at this point.
So I guess that's the reason why we call. We'll talk a little bit. So that's why we call Rahul and Pablo, and we talked about it. I mean, so this is a lady we've known since 2013. I mean, she presented with acute thrombosis post with an occluded filter. I mean, with an occluded entire system. So at that time, we went ahead and we lysed her, and then at that time, because she had recurred second surgery, I think that one of our vascular surgeons was with us. We decided to put in this Optis filter, and then basically she's been lost to follow-up.
True.
She's been lost to follow-up. She's in and out, comes back and forth, comes with some swelling when she has symptoms and comes back. So at this stage, we're thinking that, she has a tremendously swollen leg now, post-thrombophlebitic syndrome with iliac vein compression with an IVC filter in place. So I guess we're open to anything here, and she is too, in the sense of what the right thing to do here is. From what our thought was, at this stage, the IVC filter should be removed because, I mean, it's going to cause nothing but trouble in the future potentially. And do we or do we not treat this iliac vein, compression that's shown on CT in a patient that has a thrombotic syndrome? Pablo?
So yes, I think it's very important to make sure we follow up on a lot of these patients because we do lose a lot of patients that have IVC filter. And anytime I put an IVC filter, I try to bring them within 6 months, and that is very important. I'm sure you as a cardiologist or interventional radiology, you see a lot of patients that come to your office and they have filter for over 5 years, over 10 years. And here at Mount Sinai Hospital, what we have work as a team, as a collaboration, and really take us to the next level of patient care. And the teaching was maybe 20 years ago, 10 years, we shouldn't take this out. We're going to have a complication. Maybe if the straws are coming out of the IVC, maybe it has to be done open. But now with the experience of interventional radiology, experience of interventional cardiology here with vascular surgery, we're able to take care of this patient, even with filters that are out there for over 10 years. And I think it's very important because personally, I don't without any major data, I don't feel comfortable stopping anticoagulation on this patient with IVC filter. And we see so many elderly that had DVT, acute DVT only once, and they have an IVC, and we can't stop anticoagulation. So I think it's extremely important to take out the filter. So that's one thing that we really have to follow up. But sometimes we lose them. But then, with the collaboration, with the experience that we have, we can really take out all these filters out, make sure they are all anticoagulation. The next point is, IVC filter. After the IVC filter, the iliac compression is, I think if you find it on CT, on MRI, they tend to be pretty dramatic on IVUS as well. That is my experience. So I think there's a high likelihood, in my opinion, that this patient, with her symptoms that she has, she may need a iliac stenting as well.
Rahul, Srini, any points on your end? I mean, I was going to ask Rahul what he looks for on the CT to see whether these filters should come out. What are some of the tips and tricks you can teach the cardiologist?
I mean, the first thing is just identifying what kind of filter it is, right? So sometimes we have a lot of patients that come to us that the filters were placed elsewhere, or they don't even remember they had a filter placed. And so the first thing is just trying to identify the filter, make sure it's not broken. So if it's broken, it actually makes us more tend to take it out, because if it's going to break, broken once, it's going to break more. And then, looking for penetration. This filter is not known to penetrate the IVC wall, but some of the other filters are known to penetrate the IVC and are more prone to fracture. Obviously, you want to look at thrombosis, tilt are the other things we want to look for. And then, I think in patients who are younger, on the healthier side, we are recommending taking almost all of the filters out. Some of them we do have to balance, obviously, the risk of taking the filter out versus, how old they are. We have 85-year-old patients who are coming who are bedbound, probably just going to leave the filter and not really worth taking it out. But we've had patients I had a patient who was like 35, had a greenfield, placed when he was a child, and he was having pain. Like we took that out, right?
Took that out.
Yeah.
Wow.
So we've taken the ones out 30, 40 years out. So filters don't even exist anymore. We've taken out. So so our techniques have changed a lot, have improved a lot. They're not necessarily always elegant. It's a little bit of just a brute force, but yeah. So, but you just have to be prepared for all the sort of possibilities that can go wrong.
Go ahead. I just ask, do you do routine imaging before you take these out?
Yeah, so everyone gets at least a non-con CT, for obviously a CT venogram before.
Okay.
So that's we get a CAT scan. Sometimes even an X-ray. Sometimes you can't tell exactly what's going on. So even sometimes just a KUB is helpful.
KUB.
Yeah.
Okay. Wow. Srini, anything?
Well, thanks for the invitation, PK. Great to be here. Rahul and I have known each other almost 15 years or so.
Yeah.
So it's been a long time. But I think, this case really shows you a couple of things. One is that venous disease is much more prevalent than PAD. And when you think of how much PAD we see in the US and the world, there's almost 20 times more venous disease. The second thing is that I think we're doing a better job at follow-up and filter removal. If you look at the latest data around 2014, I think about 1 in 4 were being removed compared to 1 in 7 a decade before. We're not perfect, but we're getting better. I think another important point for everybody, your listeners especially, is that, these filters, and we know this from a lot of the data now, is that after about a year, these filters are not really helping you as much as we think. And what's happening is we're starting to see all the complications that Rahul and Pablo and everybody are talking about, from thrombosis to stenosis to deep venous reflux because of occlusion and obstruction and so forth. And so I suspect that this patient, even once you take out this obtuse filter, which is a tough filter to take out, by the way, is that there's likely to be chronic thrombosis plus stenosis in that inferior cava. So you may have to do some level of revascularization in inferior vena cava as well. So great case. Really glad to be here. Thank you.
Yeah.
So question now, Rahul. I mean, we want to do the IVUS, and we'll do it. I mean, how do you handle these cases? What's your steps?
So again, I think we look at the orientation. So obviously you can't see the picture. So this,
you can put the picture up, guys. Put the angiogram up for us.
So this is just a quick venogram, and you can see the filter here. So one, it's an obtuse because it has the hook on the bottom. These were designed to actually come out within the first 6 months. So we're way past that. So the sides can get a little embedded. So here, if you notice, it's a little bit tilted towards the bottom apex is tilted towards the right. So that's sort of how I would choose which side to go to remove it out of. So we'll come from the right, so everything's sort of in our advantage. So when we have to pull this down, our sheath will kind of track right up over it and slide over it. We've prepped the neck as well, just because sometimes if it's really embedded, you may have to what we call Chinese finger trap and kind of come from both ends. We're sort of prepared to try the different techniques. So I tend to try to do the easiest first, which is just snare the bottom, see if I can I get lucky and it comes out. If not, then I'll escalate pretty quickly and move on to either. For this one, I kind of like what they call the hangman technique, which is basically to take a sauce, and we'll probably end up having to show it to you, is just to hook the bottom apex with a sauce, bring a glide wire down, and then snare it. So you have like it comes as almost like a lasso all the way around, and then you have it hooked. And you have to do both ends. We also have forceps, which are the Limal forceps, which are on a metal rod. They're actually endobronchial forceps, and sometimes you have to use those as well just to get enough grip and force to pull it out. These ones are also somewhat notorious for coming apart. So I was telling PK earlier that we have to be prepared also for just the two apexes to come apart. And then what you're left with is the side arms that are just too embedded in the IVC. And then that's actually okay because it's not really an obstruction to flow. And so that's sort of what I look at. The other thing is obviously if we had an extensive thrombosis going all the way up through it, you could also make the argument, and then there's data to show that it doesn't matter whether you take it out or just stent right through it. Here, obviously, we're not going to stent through it because the problem's not there.
Yeah.
But
So Rahul, can you tell on CAT scan that that it's embedded in the wall or no?
It's hard, but if it's touching the wall and it's been in that long, it's going to be embedded. Whether it's embedded to the point where I can't get it out, I can't really tell.
You can't tell that
until
And your technique of getting it out, do you try to wiggle it, or I'm just curious on what your thoughts are.
Pull really hard.
Just pull really hard.
Yeah, for this one. So the ones that are more like the umbrella shape, so the Greenfield. So the Greenfield has two sets of hooks that are counter oriented. So you have to actually sort of twist. I tend to twist it almost like sort of like you're taking out a
wine cork.
Well, yeah, exactly, a wine cork, and just sort of cork it out.
So in terms of filters, I know these aren't used much anymore.
Yeah.
Are the newer generation filters easier to take out, or are they all just kind of the same?
They're a little bit easier to take out because these ones, again, after 6 months, it gets pretty embedded into the wall, the sides. The more conical shaped ones are a little bit easier to get out, but they're a little bit more prone to tilt.
Yeah.
And so they're also, if you want to go, and those are sort of probably ones that came out in like 2008, 2010, 12 range. Now, if you talk about the more modern ones, they're actually ones that are convertible. So they're ones that have like a dissolvable suture in the middle, and it just pops open. So you don't actually have to remove it. There's one that actually has just the hook in the middle. You just pull out that hook, and it converts into just basically a big IVC stent. And then there's one that's not approved in the US yet, but they're actually starting a study from Adient, which is actually the whole thing just dissolves after about.
Oh, so it's a bioresorbable.
Yeah. So it has two metal hooks that stay on the wall, but the whole thing is just bioabsorbable. Yeah.
So Pablo, go ahead, Vishal.
No, so I guess there was a question, which is I think from a clinical perspective. Let's say a patient presents with you who's asymptomatic. In this case, of course, there's a lot of symptom-driven intervention. But if it's an asymptomatic presenting, at what time does the table tilt where the risk, you'll say, is more than a benefit? Like a 45-year-old guy walks in, like Rahul is saying, 10 years later, had an IVC filter when he was a kid or a young guy. Now he's like, I want to get the filter out. But my question is, when do I say, no, now it's too risky for you, so we leave it because it's hanging for 10 years, versus, no, it doesn't matter, I'm going to still pull it out? Like, where does the balance tips towards the other side? That's the real question I guess I have.
Yeah, so that's tricky. I think it really depends on the filter type, because I think, for this filter, I think if she was completely asymptomatic, never had any issue, even though she's in her 50s, you could make the argument just to leave it be, right? She's going to be on anticoagulation anyway. You could probably make the argument just to leave it be. But if she had like a more of the conical shaped one, I think those ones, the risk is lower.
What is the risk of leaving it be? Can it thrombose? Can it erode? I mean, is there a way to predict it, Pablo, in these kind of cases?
Not for this type of filter. I think erosion, as Rahul said, is very minimal. But with the other filter, like the Select are known they can erode because they have a lot more legs that can come out of the IVC filter, and we have seen it going into this mobile and cause some major problems. So I think those filters will be more prone, and I'll take a little bit more risk to remove it. Now, these are questions that we always grapple with any case that we do. When we do a carotid, can a 19-year-old do an open carotid or not? And you have to see the patient in the office. I see a lot of patients in the range of 60 to 90, that I think if they're independent, if they're walking, my preference is to take the filter out and get them off anticoagulation. Because I think a lifetime anticoagulation is not, it's risky as well.
Sure, no question.
So we really have to go by case.
Perfect. So for the sake of time, we've got bilateral accesses. We're going to do an IVUS of the left iliac for now. Let's go. So let's do a quick IVUS here, Floro, and Rahul, you can go
Or
ahead,
actually,
guide
Bob,
us
you wanna
through
talk
this
about
here.
the-
Can you tell us what size sheets do you have right now in?
So we decided here to go with an IJ. We just put in a 5 French in the IJ just to have it. We've got for the sake of time, we've got bilateral 10 French sheets, which we're ready to upgrade to whatever Rahul and Pablo need. And me and Rahul were talking. We just do a quick IVUS to kind of demonstrate what we're seeing on the left iliac, to confirm what we saw in CT, and then decide, I guess, the next steps. I'm going to leave it to those guys, to both of them. So let's record, guys, and then I'll put the IVUS up for the audience. So you can see the struts of the filter. I'm at the bottom of the filter there. I'm just going to slowly pull back and let Rahul just kind of read what he sees.
Yeah, so here we're still in the IVC. We're coming down still.
Just going real slow.
Yeah. And then here's the getting into the bifurcation. You can already see there's some wall thickening as we're coming into the left common iliac vein. And you can see, if you get a sense here, the left common iliac vein is very, very narrowed, and a lot of sclerosis around the vein. There's a little bit of compression there. And you can just see the vein is very small, but and it's a little bit of compression there, usually at the sort of level of the hypo or coming around the SI joint.
Mark?
So it's pretty much around the catheter.
Yeah, exactly. It's
Yeah.
very, very small. So,
Yep.
Some of these cases can be tricky because it's like, oh, it's pretty round. It looks pretty good. And I think here you're in the sheath.
Okay. Yep.
We probably
walk
will.
it
We'll eventually have to pull the sheath back, but it can be
You
very
want me to
tough.
pull the sheet back and continue the IVUS all the way to the end? Let me do that.
Yeah, because
Hold on. Let's stop recording, guys. We're going to record another one.
I'm going to guess this goes probably all the way down
Let's
close
see.
to the common femoral.
I'm just going to go up a little bit here. Okay, start recording here.
Yeah.
Just do a quick pullback here. This is pretty much the external,
Record, guys.
internal, and then now here. Record. Yep. There you go.
Yeah. And you can see even the external is very,
Very, very
diminished.
small. Yeah. And a little bit of maybe
And you can see some
thrombus.
calcium and some thrombus there.
Thrombus there, old chronic.
Yeah.
And then we're coming into, yep.
And you can see there it's very, very tight.
Wow.
Right at the ligaments, and then hopefully it pops up a little bit more, but it may not.
It may not.
Yeah. So even the common femoral there's a little bit jacked.
Yep.
So these,
Walk it up.
yeah. So these cases are always a bit trickier. But you can get sort of fooled because it looks good on this side, but if we didn't run up the other side, but we did a venogram on the other side. It's the iliac vein is quite large, so there's definitely
Flush
a big
forward.
size mismatch. And Pablo, I don't know, you see a little bit more of this stuff than I do, but
Yeah, the tricky part about this is if there is stenotic area beyond the femoral vein, what would you do? And do we stent across the inguinal ligament or not?
Yeah.
And I think for to make sure that the stent stays patent,
Yeah,
sometimes we may have to.
yeah.
So I'm just going to do a venogram of the other side, as Rahul was mentioning. You can see the size of the vein is quite large compared to the other side, which is quite small. If you want, we can do an IVUS here as well, Rahul. It's up to you.
I don't
You don't need it, right?
Yeah.
Okay, cool. So anticoagulation-wise, Rahul, we gave heparin, which is obviously reversible. Last ACT was 250. I think we're pretty reasonable for this kind of situation. And now you've got the IVUS. So
Yeah.
what do you guys want to do?
So I think before we stent, we would actually take out the filter
Yes.
before we stent.
Right.
So I'm actually going to prepare as if we're going to try to have to rip this thing out. So if we were just going to snare it, we would probably just put a 10 French sheath in and an 8 and then try to snare and then sort of collapse it down. But I'm not terribly confident this is going to work. So we're going to actually upsize to an 18 French sheath here. So from the groin, I actually like the centrant sheath. It's a little bit more rigid. It's also about the right length. Unfortunately, it's not long enough to do it from the neck because it's only about 28 centimeters in length. So if we have to come from the neck, we have to use the Cook sheath. So the Cook sheath is nice in the sense it has the right length, but unfortunately, it doesn't have a lot of great columnar strength. When you're trying to rip stuff out,
I've
it
got a
tends
little nick there for you.
It should be okay.
Right.
I think this is pretty.
Raul, do you mind giving us a dry cine of the filter itself to see the orientation? I know we have a DSA shot. The audience would like to see a magged up dry cine just of the
Sure.
filter.
Let's just get the sheet in. So we're putting it. So we're on a supercore wire. We've got like a little nick going in the groin, and now we're going to get this up right now. So I'm just on fluoro for Rahul because it's a new room. Obviously, it's different in every part of the hospital. So there's the sheet goes up to that spot.
Yep.
So if you can put me on coronary, my friend,
yeah,
and
yeah.
mag it up for me. I'll just want to show everybody.
Yeah.
There you go.
And
Mag it up. Mag it up. Oh, I
The
can
shutters
mag it
on the
up
side,
here.
yeah.
Yep. Okay,
You
here
know,
we
I
go.
think there's a
Yeah,
key
beautiful.
thing is that
Nice.
There it is.
amazingly for how long this filter has been in place, the vena cava and everything looks a lot better than you would expect. You know,
Can I get the
now,
8 French sheath? Sorry.
without that's fine. I think the second thing too is if you notice, Rahul put in a very large sheath to start, and I think the mistake is because we're a big referral center for a lot of filter removals. Is that we used to start with smaller sheaths, and then you would
Yes,
start
get rid of this.
you would get stuck halfway through. But now we really
Yep,
putting
that's
in your
floral.
6
Yep.
sheath
Yeah, I remember-
from the neck,
Exactly.
the groin.
Yeah, I remember first doing this.
Floral?
I'm pretty
This
sure
is
I've
floral
had
for you,
to
yep.
call Pablo to come and do a groin cut down because I gotten one stuck in the groin. Using the right sheaths, especially if you have to rip it out backwards. Some of the other ones, like the conical shaped ones, will actually invert the filter to remove it. And if you do it through the wrong sheath and from
You
the,
need the
no,
sheath?
actually,
Okay.
we're gonna try this first. So
The snare first.
the snare first. Yeah.
Yeah, I think that's a very good point Srini brings up.
Patient on the general.
So now, Rahul, equipment-wise, what are you using?
So I put an 8 French sheath in. So I like to, if we take these out, I like to telescope over it before I pull the sheath out. So this is just a
Can
snare.
you zoom in on Dr. Patel's hand, please?
So it's just a simple 20 millimeter loop snare. So we're gonna try and see if we can grab the hook. Sometimes what's gonna happen, because it's been in for so long, the hook may just fall off because it's been.
Really?
Yeah.
Oh, wow.
You get. It's
So
weird.
can you take off the hemodynamics and just focus on Dr. Patel, please? Take off the. Thank you very much. And then you got to show
You
fluoro
wanna
as
run
well.
the
Yes.
snare.
Fluoro as well on the side. Thank you.
The other thing that I definitely made a mistake when first doing these cases is not doing this on the general. Now always these cases are done on the general, because if you can't take it out with this easy way of snaring it, and you have to use those forceps, it can be pretty traumatic for the patient. So I highly recommend doing this on the general anesthesia.
All right. So you can see we kind of grab the bottom. So what we're gonna try and do, see if we can come down and slide down and grab the hook.
And I think
Okay.
that if you
So I
notice
grabbed
the
the
key
hook.
thing-
Yeah. Go ahead.
Go ahead,
Do
Srini.
you have a hemostat?
Sorry,
Hemostat, sure.
the fellows always ask me this, and
You
you'll
can
see
just
this
clamp
is
it
that
close to the.
people think you can grab any part of the filter, but if you notice, he made a really specific point about grabbing as distal as possible, the very end of it, because otherwise you'll have trouble getting your sheath in. You may end up tilting the filter more than you want, and so forth. So that's a really key point when you're trying to do these.
Oh,
Yeah,
it's
so-
actually.
So that's a very important
Can you-
technique which
can you
Rahul
attention
just
here?
did, is just telescope the 10 over an 8.
Good.
No, no, you
just,
go.
just-
Try to
Yeah, so-
capture it.
yeah. So that's basically what I'm gonna try and do is just.
So Rahul, what are the telltale signs you look as if your filter is going to break? Is there any telltale signs you can look by pulling to say it's going to break, or it's just
It's
chance?
it's not gonna work.
Take the wire out on the other side.
Wow.
Yeah, you have
Part
to
of,
sometimes.
part of it is you get stretching
is
as well,
this
right? You
going
get
in?
stretching, elongation,
No, it's good.
fracture, and so forth.
Oh,
Or
we
your
lost
snare
it.
just
Oh.
breaks and comes off. And so that's the reason for the telescoping of a sheath inside a bigger sheath.
Cheap.
And often, like
sorry.
Rahul
It's
said,
okay.
you may need access from
I
above
think we still
because,
have it.
even though on CT, it doesn't look like the wall is fibrosed or scarred
Okay, I think we-
into the filter itself. A lot of times these filters are more scarred in. And anecdotally, we've seen filters that have been in for a month that are tough to get out. We've seen filters that have been in for 10 years that come out within 2 minutes. So it is really very hard to predict sometimes.
Yeah, it's hard. So I just need to pull here, right? Yeah.
Mhm. So you can see here that they're just sheathing it, and you can see that.
Nope. it broke.
So the filter broke, huh?
Yeah.
Yep. So the filter snapped.
The hook snapped.
The hook snapped.
Can we put it?
Yeah.
Yep. Now we're gonna try to go with the forceps.
Because it's half of it is already in
Yeah.
the 18 French sheet.
So-
So, I think we're
Let's open the forceps,
Yeah.
Pablo.
Yeah.
So you can see that it's excuse me, Damien, can you open the forceps? So what you can see the amount of effort that it took two of them, and you see they're much bigger than me, and especially Pablo here.
Just one. They're both the same. They're both the same.
They're both the same. So Rahul, can you talk about these forceps for us?
So
a
these
little bit?
are they're called Limal forceps. They're actually endobronchial forceps. Let's see if I can show you this. They're on a metal rod. I'm gonna see. Oh, there you go.
Yep. Can you zoom in on Dr. Patel, please? His hand.
The other hand, yeah. The
Yeah.
right.
Yeah. Thank you.
Yeah, here I'll try to bring it here. So you can see it. It opens and closes, right? So it's basically one side opens, one side stays the same. This one's already has come pre-bent, which is fine. A lot of times we'll bend them because you have to, going in straight, you may not be able to grab what you want to grab. So so we're gonna basically just put this in.
So is this with this? Do you twist and stuff, Rahul? Or
no? You may have to twist. So sometimes you can use it as a blunt dissector if you have to.
I can hold this sheet for
Thanks.
you.
Mhm.
Oh, you know what? That might actually be the problem. Oh, I think we should have enough length.
So, I mean, for those of you who are not doing this on a regular basis, you can see how involved this is and how you need to get somebody with the expertise that I'm lucky enough to have at Sinai. We have, obviously some of the best operators in the world. And you can see here all the equipment that you need to do, all the stuff that you need to do, and you can see that now they're pulling it out.
Nice.
Yep. So a little bit more came out. So they're just trying to go in there and grab it.
1 second.
So this
At least
is
the
one really great technique, right?
Let me know when I have
Forceps
to
either
push
from
up.
above or below. You
Huh?
can sometimes a sheath from above to help remove that, free the filter.
Yeah, we may have to come
away.
from above as well.
Yeah, so that's why we did get that, Srini, like you said, and Rahul had mentioned it to us, but I thought we could try it from below, and then now we need to come from above, we will.
Yeah, no, these filters sometimes can be very difficult to remove, as you all know, and it's Spectranetics, which I think now was owned by Philips, but there's a laser sheath you can also use to help kind of.
We do have that in EP. We can bring that down if you want. It's really what Rahul wants to use because we've got all that available here.
Then we're gonna have to come from above.
Okay, so we're gonna come from above. So what sheet do you need, Rahul? Another super core wire, please. Yeah. Another super core wire. We're gonna come from above with a super core.
They can't really grab it anymore, right?
But this is a great demonstration,
You
PK, to
can't
show
grab
you
it.
that these filters
Maybe grab it
they
and twist it.
They should come out very easily, but they just don't sometimes.
Yeah,
And,
well,
Yep.
mess it up.
Right.
And
I just
grab it and twist it.
Yep. I
around.
think Pablo, if you could elaborate what you're saying for the audience.
We're trying to twist the sheet.
Yeah, we're trying to grab it and twist it around and see if we can get a bit of hold of this and try to pull it out.
So I'm sure you don't have enough brute force where you pull through the forceps and still try to
It's
track your
it's
sheet
almost
up.
out. You
You
can
try to
see-
pretty much dislodge it from the
can
wall.
Can we mag up there?
Yep,
I
we
think
can mag
have-
up here.
We got a little bit more in.
Flora. There you go.
As you can see, yeah, we got more into the sheet. I think we only have one dirt left in there. We're almost there. Oh, there you go.
Almost.
Popped
Almost.
out. Almost there.
Like I said, it's
Wow.
not.
It's not.
It's not elegant.
Yeah, no, that's true. It's one of those few end of procedure where you can be as brutal.
Well, I mean, listen, the whole idea
With
is to
safety, of course.
have the team in place.
Correct.
If whatever you need to do, you do. Obviously, this is a situation which is not easy. And you can see how embedded these filters can get after 13, 14 years. And I think you might. Now, coming from above, how will this help, Rahul?
So I can just pull. I can get the top and then sort of pull it straight, right?
I see. You basically collapse it from the top.
Yeah.
yeah, because in essence, right now, that is really scarred into the wall of the IVC.
Yeah.
You're probably pulling you're probably invaginating the IVC as well.
Yeah.
when you're pulling it.
Yep.
No?
So we're gonna come from the top. Ray, can you give him the
Yeah.
super core?
Yep.
And
I think we're gonna have to come from.
where's Dane?
Just
Super
just
core?
grab it from the top and then.
Yep, we got the super core. So we're gonna have the super core from above. I'm gonna go to low mag for Dr. Patel, and have him. I'm just gonna go on fluoro here, and just show him above, so this way he can come from above.
So as a go ahead.
Dame, can you tilt this to Dr. Patel? You might need a cheater over there, Ray.
Yeah, Srini, sorry, you were saying something?
No,
Can you
I was
tilt
saying
this?
that,
Bring it
although
up.
complications are
There you go.
rare during filter removal,
There you
you
go.
always want to be prepared with large balloons in case you do get a perforation.
Yeah.
If you're-
Right. That was my question. What balloon do you have in your back, just in case? PK, what
So
size?
we usually use a Reliant, which I assume actually you guys have up here.
Yeah, we have
Yes.
the large occlusion balloons. We have it ready if we need it.
Yeah, that's
So-
a very good
So now
point
you're
that
gonna go
Srini
with a big
brings up.
sheet now.
Yeah, I need to make a
Yes.
nick and.
Yep. Give
Man, this is
Dr. Patel a nick.
Yeah, we always have a aortic balloon ready and an aortic stent graft. Hopefully, we never get to that point.
Hopefully not. Yes.
But we always have that in the shelf.
Yeah.
And I'm sure when Rahul's getting down, you'll see he'll try to be, as careful as he can because, there's a lot of fibrotic tissue and synechia and,
Yeah.
you're not necessarily dealing with a wide open
So
channel.
one's
You may
55?
suspect if you want to be careful with slide wires,
Right,
especially stiff.
Yeah, exactly.
right? Because you can perforate, you can dissect, and so forth. So
Yep. So what we're doing now is we're going to take the sheath out.
I need a
We're
nick.
going to here's a nick. Here's a nick, Rahul. I don't want to give it.
Is there any role of trying to wire across the filter,
what-
balloon
just
it
drop
to
it.
try to see if we can dislodge it, or at least shake up a little bit by ballooning across and then trying to pull or tug?
Sometimes you do have to balloon it to get it off. I don't know if that's going to be super helpful. Can you raise the II? Sorry.
The what?
Can you raise the II?
Raise the II. Sorry.
ballooning is usually kind of early in the filter removal process, Vishal, in the sense of you're trying to get the balloon between the wall
No, we
and
need it bigger than that.
the
We
part
need
of
it
the
filter.
filter guard in, and you're trying to change the orientation so you can get
Right.
over the top. Now I think it probably wouldn't be the best choice in this case.
Makes sense, yes.
The Cook 18.
Yeah, sorry.
You're going to stick it right in there.
I'm going to try.
And I think what Rahul's going to do here is he's going to put in a large sheath. He's going to snare it from above. He's going to get the sheath over it to try to collapse it and free up that scar tissue.
Jesus Christ.
So because once he frees up that scar tissue, this filter will come out very quickly. The hard part is the fibrotic tissue. It's really tough tissue. It's amazing how tough it is.
Yeah.
Does not want to go.
I think one thing I really agree with is doing under general anesthesia, but you're absolutely right.
Do you
With so
have,
much manipulation and big
There we
sheets,
go.
I don't expect
No, I need
anyone
to
to
dial it.
tolerate how much sedation you give it.
Wire's got to go down, Rahul.
I think general anesthesia is the right way to go, which
You
makes
just want
perfect
to dilate
sense.
it by
Yes.
itself?
So Srini, you always do it under general anesthesia, or
Or you can even take this
No,
dilator.
we actually, our
dilator.
first attempt for most filters, unless it looks like an Optese or a Trapeze or one of
me a
the
flush.
older
Yeah.
filters that's been for a long time, we usually do Versed and fentanyl, and only if we're unable to get it out easily at that setting, then we bring them back with GA. But I don't think you can fault anybody for doing these cases with GA because you
Right.
can see your hard
Careful.
sheets. It can be
so this is an 18 French sheet, PK?
No, that's
a
just
dilator.
a
That's just a dilator.
Oh, sorry.
You're just dilating it. Yep. Now we're going with the sheath.
Yeah, the Cook sheath's not the best sheath because it's got a terrible step off. But
Yeah, we're gonna try to dilate it, but I'm always here. I can dissect a little bit if it doesn't go.
don't think you want to
That's
do a
the
neck.
key.
Well,
Yeah, having a
again, it's
surgeon in the room.
it's the together approach, right? Everybody's here. You got all the people that
there
you
you
need
go.
to help, and now you can see the sheet goes in. And now watch out, it's going to the kidney there. Yep. There you go. Now we're gonna just take it down to on top to Dr. Patel on
how the wire is kind of buckling on itself, not looping, because it shows you how much fibrotic tissue and probably corresponding stenosis and retraction that there really is there.
Right. Exactly.
That's a very good point, yes.
All right. Can I get the other forceps?
Oh,
Yep,
you want
the other
different
forceps, Chu. So we're going to open the second forceps. And remember, for those of you at home, I learned today that, these are not disposable. So
what I'm gonna do
you got
is
to
I'm
be
gonna-
careful and
You're gonna have to grab
make sure
from
you
the
send it
bottom.
back to your
and then I'll grab
your
from the top, and then we'll
team.
try to
Here you go.
meet the two
Here you go,
sheaths in the
Rahul.
middle, and then I'll let go, and then you can try to pull it.
Send it
forward.
back to your team. So the forceps are going to go from above and below now.
So we're gonna try both forceps. So Pablo's gonna grab it from below, then I'm gonna grab it from above.
So what we're going to do, Pablo's on fluoro. Yep, we're going to go above and below. I can go a little bit lower mag if you want, Pablo. That's good right there?
I think that's good
Okay.
right there.
Yeah,
We can
all right.
both see.
Oh, this is so awkward.
Do we have the aortic occlusion?
There you go.
I gotta see if I can grab. I think I got it.
So again, the key thing here, PK and Vishal and Rahul knows this, and so do
All right.
Pablo. But
You want to see if you
Grab-
can
No,
put your sheath up, or
I'm putting my
The
sheet.
most
I'm pulling.
20,
I'm
20, yeah,
pulling.
just so just have that.
I'm pulling. I'm pulling. I'm pulling.
Wow.
all right? So maybe I got it.
We
then.
got
I
it.
think
Okay, you got it from
I
above.
think I think.
Okay, you got it from above.
awesome.
So let's save that, guys.
You want to send your
Beautiful.
wire up from this
Yep.
side?
Oh, you want me to send? Give me a wire, guys.
No, it's right here. Just this side. Just send this wire up.
Sure.
We do.
Good. So we didn't tear apart our IVC, which
Well,
is good.
the wire goes up properly, so I think the IVC is
Much
good.
better.
So we're just
Oh,
going to
wow.
take it out here.
And there you go.
There you
Okay,
go.
let everybody take a look here. Again, you saw the amount of work that it took Dr. Patel and Dr. Kim to take it out, and there's the filter as a whole. Is there any tissue attached? A little bit, huh?
A little bit, yeah. And then, the things you obviously want to inspect the filter afterwards, make sure there's no pieces, not for this filter as much because we know we have all the pieces, but I always like to take a single shot chest x-ray, make sure there's nothing in the chest, afterwards.
Okay.
Yeah,
we'll do that.
More so for medical legal than
Sure.
for anything.
Do you guys do a venogram? Or
Yeah, we're going to have to do a venogram because you're going to have to figure
sure. So let's attach this to this sheet.
You want to do this one because there's
sure.
a lot of dead space.
So let's do it to this. Nice
Great
job,
job,
guys. Incredible job. Srini, anything on the technique? I know you do a lot of these as well. Flush forward.
Show Dr. Patel.
No, I think it was a great demonstration of kind of all the tools and all the
Okay, ready?
things you.
Yeah.
All right, ready? We're going to do a DSA, guys. So we're going to do a DSA. Ready? Inject. Now, if you see something, don't be alarmed. I mean, it is what it is. So you got to deal with it.
Or you may not see anything.
Well, or exactly,
that's
you may not see anything. So I just wanted to warn the audience not to, get crazy.
So, that is a good point, though, PK makes. So if you do see something, depending on what you see, sometimes you can just put the balloon up. It is a low-pressure system. So just putting the balloon up, it's also closed in the retroperitoneum, so you don't necessarily need to jump to a stent graft. We do have a relatively low threshold, though, to put it. So if you
that's a great point for both Pablo and you and Srini. So you guys say, God forbid, you do see a rent, right?
Yeah.
And it's not a massive and the hemodynamically stable. What is your algorithm there? You said put a balloon up. So how do you size the balloon? How long do you leave the balloon up?
So the easiest thing to do is to put an aortic occlusion balloon up. So there's no sizing, right? So you just basically blow it up until you get the peanut. You leave it up for 5-10 minutes, and then usually I would say for vast majority that's enough. Now, sometimes, especially with like the older nitinol greenfields, you'll rip the IVC apart, which is obviously not going to be fixed, and then you end up having to put a stent graft. Okay. But again, as you notice, we don't just rip it out, right? We try to sheath over, and I think where people tend to really tear the IVC is when they don't oversheath the filter. So if you do that, usually if you do get a hole, it tends to be pretty small.
Got it. So Pablo, now you tried the aortic occlusion balloon for a little bit, but occlusion balloon's not working. Stent graft. And now you're like, okay, I'm going to have to stent graft. What is your thought process? How do you size? What do you decide to do?
So I think the Reliant gives me a good idea because we have a lot of experience doing aortic stent grafting and gives me a rough idea how big this is. We can also measure. We can also put a pigtail and see and roughly measure how big it is. So it would be anywhere between 20 to 30 millimeters. So I usually put either a little aortic cuff or a iliac limb that comes in a range of 5 centimeter length or up to 10 centimeters. So that would be my our method of doing this. We're very lucky that here we have consignment, so we have all this graft ready to go whenever we need it.
So Srini, a question for you. Now you're done. What is the follow-up immediately post-op? Obviously, we're going to stent this iliac vein. But what is your post-op follow-up for the IVC, Srini? What do you do with that?
I mean, it's symptomatic, right? We usually see them at 1 month in the clinic to see if they're, in this case, this patient has, leg swelling, left greater than right. I think you're going to, treat that today. So we just follow them and see how they're doing symptomatically. We use ultrasound. The only time we get CTs post IVC filter removal is if we've had a complication.
Okay.
Or an issue.
Oh, okay. I didn't know that. Okay.
Yeah, that was one of the audience questions as well.
Oh, the audience. Okay, cool.
Yeah.
So you guys, you do a plain chest X-ray to look for debris anywhere.
We would just do it like at the, just with the fluoro, right?
With the fluoro.
Yeah, we'll
Got it.
Especially the conical ones with the ones with legs.
Right.
Because sometimes they have very small legs. You're not really sure if you got them all out. So you just want to make sure. So actually, I'll start the case with a chest X-ray because if there are already legs there, I don't want to get blamed for it.
That's a good point.
And then we'll end the case with a chest X-ray. And that's how I just teach my fellows. So start and end the case with a chest X-ray.
Okay.
So that way you know that you got everything. The follow-up, again, as Srini said, is purely symptomatic. So if they're having symptoms after the filter removal, then I'll get a CAT scan. But typically, they usually don't. They're pretty straightforward, and we'll just do this. So for the non-complicated filter removals, I don't really see them back in the office. So if it's a straightforward filter removal, usually I'll talk to them afterwards. It's done with a little versus fentanyl. I'll talk to them in the holding area, and then that's the end.
Do you keep them overnight, or you send them?
No, but everyone goes home.
Everyone goes home.
Yeah,
wow.
yeah.
Okay.
Yeah.
So for something like this, you'll keep.
No, we should send them
You
home.
would send them home. Okay, wow, that's interesting.
We have a low threshold, and the hospitals are very full.
Because honestly, we don't know, right? I
Yeah,
mean,
yeah.
we're worried about anything happening in the
Yeah.
IVC down the road. But you're saying if it doesn't happen acutely, unlikely going to happen.
Exactly. Yeah.
down the
So
road.
obviously, if she wakes up in excruciating pain,
Sure,
then
sure.
yeah. But it's pretty rare that they have to stay. I have to
That's
say.
great.
Yeah. I don't know, Srini, what's your experience with keeping patients? or
Yeah,
not?
no, Rahul, same. We send them home the same day. And again, unless we had a complication like a perforation or some type of injury like that, they all go home the same day. And PK and all the cardiologists know this. Right atrium is the lowest pressure point in the body. Blood naturally wants to go there, not out into the retroperitoneum. So low pressure system, you don't really have any problems,
Right.
knock on wood.
Right.
So-
and you restart your anticoagulation next day morning, or you just send them out on a pill, or how does it work?
Well, especially in this case, right? Because
So-
we know that we're going to stent this iliac. We're going to have to leave her on anticoagulation for a little bit. So, what's your thought?
if it's just a straight filter removal, if it's going to be very, very complicated, I tend to take them off their anticoagulation and then start the Lovenox basically before they go home or whatever. I usually give them a dose of Lovenox and tell them to start their DOAC the next day when they go home. If it's not super penetrated or anything, actually we'll leave them on their anticoagulation. We don't tend not to stop
Oh,
their
okay.
AC.
Oh,
Yeah.
wow.
What's
Okay.
That's a good
How about
point.
you,
Yep.
Pablo? Anything different on that?
No, nothing different. Nothing different. But I'm a huge proponent of stopping anticoagulation after this.
Yes.
So
Oh,
the
yeah,
next,
so that's a
the
different
next
problem, yeah.
day, if it's not a complicated case and they didn't have a major PE or anything like that, I would probably start on aspirin in day one and no more full anticoagulation with the Novox or Coumadin or any other agent.
Yeah.
And I guess one of the audience had a quick question for you as well. Would the IVUS being filled up with a chronic thrombus change your strategy in pulling, pushing, or any of the techniques, or anything changes? It remains the same. I mean,
It's
here we
still-
tried to IVUS.
It remains the same. Although this filter, we've seen a couple of them where it's gotten filled with clot, and if it's been in long enough, it's actually calcified within it, and those ones you're just not going to be able to get out. So those ones will just end up stenting through. We had one which it looked like a boulder inside the IVC. So those ones you're not going to get out. But if it's chronic, we've done ones where it's just occluded, right? It's chronically occluded, and we've taken them out. There you can actually be a little bit more aggressive because the IVC is occluded, right? So you're not really worried about it bleeding at that point.
Got it.
And you're probably going to end up having to stent through the occlusion later. So
Right.
So we've got 10 more minutes, Vishal and Srini. So what I want to do is now talk to both of them about stenting this thing, and what's your technique that you guys do in terms of this filter. Can you play the IVUS so they can look it over the first run, please? And how do you guys size in this type of very chronically, obviously it's compressed and scarred down iliac vein? So let's go. Let's start from the IVC. This is, again, for the audience, this is starting from the filter and coming down. Now, which of the areas you guys mark and measure? I'm just curious on how you would do it. So here's the IVC coming down. You can see the IVC.
Looks good.
You're going to see the confluence very shortly, and then there it is. And now you're going to see the ostium is going to get really, really compressed in a second, which shows that you really do need
Right
to
there.
take care of that compared to the contralateral. And then now you can see the entire segment is pretty much compressed. A little bit better there. And then it gets worse as you get further down into the external iliac vein. So how do you size this, Pablo? I mean, what do you do?
Yeah, so I think with the newer stents that are indicated for iliac vein stent, the treatment modality for me changed a little bit. With the Wharton back in the day, Boston Scientific Wharton, we used to cross the IVC, and we're okay with that. Now I try not to get into the IVC if it's possible.
Got
if
it.
I have to get into the IVC, I'll try to put two stents on
Got
both
it.
sides because we don't want any complication of creating an acute DVT on the contralateral side.
Sure.
So that's number one. So I look at the IVUS, see where the lesion starts, and start from there.
So here it looks
And
like
then-
it's the ostium, right? It looks
and-
like the ostium, but
Yes.
They still have a little bit of room. Yeah.
And the sizing of the stent, I try to go by the IVUS. We look at the normal area and we try to.
But in this
measure-
kind of case, I think
Yeah.
is the audience would ask you, like, there is no real normal area, right?
I agree. There's no normal area. We try to see if there's anything that looks like a normal area. Undersizing is a major issue.
Yes,
in cases like
exactly.
this. So we never want to undersize anything like this. So
Right.
I almost never go below 16.
I agree.
It's always
Yeah.
16 to 18 to 20,
Yeah.
but I never below 16. I think that's a mistake that a lot of some operator can make.
I mean, there are
Yeah.
obviously one-offs. You have some tiny woman, then maybe a 14. But even then, I still put 16s and just dilate it to 12 and let them get to 16 naturally,
Got it,
because they're all
right.
self-expanding stents.
So what would you guys choose here? Would you go with the 16 or an 18?
I'd
or
probably put a 16.
Yeah.
16? So we
or
do
18,
16
but-
and the longest you have, right?
Yeah, so here I think we're going to hand the stenting down all the way to the ligament. And then the question is, what do you do about the common femoral?
Yeah, so the question is, a lot of time we try not to go past the ligament because that's the area that we've been.
16 long.
But I think having this much amount of stenosis in that area, you sort of have to stent below because you want to also think about the patency of the stent later on.
Yeah, so I mean, sometimes what we'll do is we'll come over, come down, and then, because obviously we can't, right now we can't balloon through this to get the common femoral, so we'll come either up and over or come down and then balloon into the common femoral and just try to balloon the inflow to improve it.
So we could do that offline, I guess, once
Yeah.
we do this. That's a great idea.
Yeah.
So Damien's got to get the stent, and so you do a 16. How do you? There's another common question we all get asked, and I guess we got all three of you here to ask. How do you hit the ostium? How do you determine where the ostium is? Do you mark on the screen? Do you guys have a contralateral catheter or some sort to kind of give you the ostium?
It's still the hardest one. So there are
Yes.
different stents that are designed to overcome that issue, right? So we don't use a lot of wall stents anymore, and I think those ones were very hard to nail the ostium, which I think Pablo sort of alluded to earlier. I think the barred stents, they have that flared open end, so it's about 20% bigger than the actual diameter of the stent. It's designed specifically, more or less, to basically flower into the IVC, and so you basically pull it down
right.
onto the ostium. And you can do that with the Medtronic stents as well. It's a little bit harder because it doesn't flower, but it does kind of give you the same effect. There's there are other stents that are not available here, but there's like the Duo stent, the Bentley.
Now you bring up a great point for the three of you. Actually, Srini, you can answer this one. Is there any preference? I mean, we get asked all the time. Do you guys, if and a lot of the people, in the community, the hospital says choose one stent. They're not going to give you 2-3 stents, right, Pablo and Srini? So what do you guys find a major difference between, say, the two leading stents, the BD and the Medtronic stent, or no, Srini?
So I think one of the problems is we don't have head-to-head, right, between the original wall stent by Boston Sci, the Venovo by BD, and the Medtronic. I think it's the Abre, right, Rahul?
Right.
And anecdotally, what really busy venous operators are telling me and saying at a lot of the meetings that I go to is
150 or no?
Abre stent because of its radial
What about
force.
BD? No 16s in the BD?
And so that's the reason why. But again, there's no head-to-head comparison. So I think it really boils down to dealer's choice.
So we've got 120s in the Medtronic, and I asked him to just go back there. Again, we're lucky, all of us here at Sinai, we have all two that we can pick from. So he's going to look whether he has longer in the BD. But obviously this goes through a 9 French system, and we can get ready. So any other questions, Vishal, on your end?
No, I think that's a great point. The audience already looking at the outflow. The outflow in this case looks a little bit compromised, so affecting the patency of the stent, I guess, becomes an issue. And then Rahul pretty much answered it rightly. Is like you already have a right-sided axis. You can technically go up and over, just balloon it to make sure the outflow is still maintained.
Oh,
and then
inflow,
it needs to be done.
Inflow.
I mean, inflow. Yeah, sorry. Yeah, inflow.
So
the reverse.
So the question is, I guess, when do you stent the common femoral pops? I mean, you were talking a little bit about that, right?
Yeah, I try not to.
Right.
But
Right.
sometimes you don't have an option. I mean, if it's severely stenotic and you have to do it, you have to do it. I have very few cases that I've done that.
So you just balloon it, and see. Hopefully, it doesn't recoil. Or
But
it
I try really not to go past the common femoral. And try not to go past the inguinal ligament if possible. But rare cases when patients have a femoral popliteal extended into the iliac DVT, severe cases, they can present like that.
Yeah,
So,
we had a case of a young man who came in, and same thing. We left it alone. We did the balloon. We stented obviously what we needed to, and lysed what we needed to. Then sent him home on anticoagulation. 7 days later, he clots off and comes back with the common femoral completely collapsed and clotted off.
Yeah.
Ballooned it again. We sent him home with a larger balloon, kept serially ballooning it. So far, he's been okay, but it's worrisome that this can, obviously thrombose off again.
I mean, the failure I see in the common femoral is that I think you look at it, you're like, oh, 12 millimeter or 10 millimeter seems right, but people don't walk around with normally with a 10 millimeter common femoral. It's like 16, 18. So I think, again, you don't want to obviously oversize so much that you're rupturing it, but I think you do need to be very aggressive in ballooning the common femoral. And, we'll make the effort to go down into the SFV. It's for fun to do kissing balloons if we have to, because, again, I think once you start stenting below the inguinal ligament, we know it's going to go down and they're going to get worse, right? So, yeah. So it's
how about surgical options, Pablo, as a surgeon? Any surgical options for this kind of common femoral issue? Say you do this and you deal with it. I'm just asking for the audience-wise. Anything?
Surgical options are very tough. I mean, we have done a lot of open venous revascularization with no major success. What I can tell you is that if, let's say, we have an acute DVT and we don't have the option of a thrombolysis or catheter-based therapy, we have done Foley catheter embolectomies, and what we do at the end is an AB fistula between the femoral vein and the artery. So and the reason for that is to increase the inflow.
Okay.
So that's something that is not proven, but it can be considered if you want to increase the inflow, make it fistula.
Although that's only been done in surgical bypasses, not endo.
Yeah.
I know the Michigan.
That's the scenario where the patient is pregnant or had a recent surgery. You can lyse them. And
although nowadays with there's new, especially on the acute side, there's so many new devices that don't require TPA. If we had to, we could do it.
Okay, so which stent do you guys want? I want you guys to show us your techniques.
You want to do a 16,
what do you guys like out of the two?
Yeah.
So we have both BD and the other one.
Stand all the way down.
Yeah, I think so. Yeah.
Try it.
Anything in particular, Rahul? Pablo, we have both.
Do you want Abre or BD? I don't really care.
I want to use Abre, but
yeah, sure.
Whatever you want. I mean,
let's do the Abre. So let's take.
We're gonna get the Abre, please. We're gonna get the Abre, and we're gonna go ahead and get started with this.
Yeah, and as you said, I mean, we chose the Abre here. I do think it has a little bit more radial force, but there is no data to show this is actually better than the other. There was a Boston Scientific one that was out.
Yes.
Yeah, so that one got pulled. I don't think it's ever going to come back, but it was a little bit different. That was a closed cell design. That one had a lot of radial force. There's one from Gore that's in study now, which seems interesting. They actually have an IVC stent, so they have the bigger sizes. Again, I think per the IFU here, it's not such a big deal, but we do size these stents, especially for non-occlusive lesions. We do use the IVUS to size them in terms of placing them, because you don't want to undersize them.
Right. So I think
Rahul,
go ahead.
Sorry.
Go ahead. No, my fault.
Any role of pre-dilatation with a balloon in this case?
So if it's a CTO, then yes, but for
the floor is right there. Yep.
Yeah.
Yep.
For this, I don't think we need to pre-dilate. It's sort of like an external iliac artery lesion. You need to just be careful where I think you're flexing the IVC.
I got it.
Yeah.
Mm-hmm.
You want to make sure.
Okay, good. Okay, you want to take some dye through the other side?
Yeah.
You can probably inject through this. No, you probably can, right?
You can.
Right? So
it's a 9 and a 10. You
just cover it up with a little, so you don't spray or something.
Just this button.
Yep.
Mm-hmm. Sorry, I don't want to blast myself with radiation here.
Yeah, exactly. Bring the Yep. There you go.
Oops,
cool. Go ahead.
A little bit higher.
Close. Yeah, I think we need to be a little bit higher.
Yep. Yeah.
So in terms of positioning, PK, you're asking about this. I mean, you can imagine there's 20 different ways to do it. Some operators will venograms.
Another one.
The sheath.
I can give a little more dye. Hold on.
Some will put a pigtail up one side.
Yeah. Do you actually have a pigtail?
Yeah, we have a pigtail.
It'll be easier.
Get us a pigtail, guys.
It'll be easier if we just put a pigtail up the other side.
Yeah, absolutely, because we want to show them the techniques.
Yeah, and then once Rahul
the
does this, a lot of times operators will lock the table, they'll draw on the screen. I mean, there's so many different things you can do.
He's just gonna put
because
that
you
in
want to
there.
make sure you don't miss.
You might need a cheater, Ray.
Like Pablo was saying, there is about a 15% chance of contralateral acute DVT if you extend too far into the inferior vena. I
think so.
Cool.
Yeah, I think that's a very important point.
Is that also data with the newer stents, Bastrini, or is that all older stuff? Flor?
Old wall stent data.
Yeah, that's what because I've been hearing from the companies that's not true with the newer stuff. So I'm not sure.
Yeah, no, I think you're right. You're right on. It's old data basically, and so I think it just shows you kind of we think that we need data in the PAD space, we definitely need it even in the venous space.
There you go. Yep, yeah, let me get.
Yeah,
thank
so I
you.
think this is a good point where he's marking with the right side. I usually also do it like Srini talked about. IVUS it, lock the table, mark it on it with IVUS guided so you can actually see the confluence.
Oh.
Of course. So that's another lesion of. But getting a pigtail obviously also helps us to angiographically define the anatomy. Or you could do a combination of two to really if you're not really sure. So yeah, definitely.
Yeah, and these newer stents, they have a much better delivery mechanism than the old wall stents. So again, I still like the technique of bringing it up over the bifurcation, flowering it, and just bringing it down,
Putting it
pulling
back.
it down.
And you're not worried about it. One of the questions we often get is, are you going to hurt the by pulling the stent down that's deployed? Is that anything going to happen?
No, I mean I don't. Obviously, within reason, you're not yanking it, but we just pull back until you reach tension, and then you're pretty good. I think it's up, right?
No, I don't think you're there yet.
Yeah, there we are.
Oh, there you are. Yep. Perfect. All right. Do you need dye in this or anything?
Yeah, so
Okay,
it's
this is dye, I think. This is dye,
Yeah,
right?
that's
Yep.
dye. Yep.
100%. Yep.
I can do this, I swear.
Yeah. You tell me when. Yep. Tell me when.
Let's see, where's the pigtail? Okay, here. So maybe just a little bit higher, probably, you think? Or you think we're good there?
Yeah, again, we have a different technique. I try to obviously mark all the areas and then look at the bony
The bony landmark?
structure and then just lock my
sorry,
eyes
that
on the
was
bony
me.
structure to deploy this.
Yeah.
Yeah.
I think we look good. Maybe a little bit back because
Yeah, I think we
confluence
can
is
flower it here,
lower.
though, yeah?
Yes, and then you can pull it back.
It is
Yeah,
right there.
I
We
injected
can-
through
Yeah,
both.
we can start there,
And then sort of
and
pull it
then
back.
we can start deploying.
That's why I
Maybe
just
right
I
there.
just did both
Yeah,
there
yeah.
for you
I think
guys.
that's perfect.
Like right here?
Yeah.
And then the
Wanna
end of the
Pablo?
pigtail is right at the confluence.
No, good, good.
Yeah, please. Come on, Rahul.
All right, so again, the Medtronic one's sort of a wheel back. It stays pretty
Triaxle, yeah.
stable. Yeah. So you can see it does jump a little bit, but here it's flowering, and I'm going to pull back a little bit.
Yeah.
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 Yeah,
Oh,
we're
that's
good
beautiful.
there.
That's beautiful. You got it.
Yeah.
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 And we know the sheath is all the way back.
Yeah, our
so we're
sheet's,
good.
yeah. It's also only 120. Yeah, we're done.
Perfect.
Cool.
So now we can let me walk
Just make
this
sure,
out
make
for
sure
you.
before I get. Okay, yeah.
Yep. So I'm just going to walk this out. So now I guess the question becomes a little. Yep. Is now down below, right? So let me show you below here. Let's do a cine. Yep. Cine, go ahead. And you guys can tell me what. That's fine. We'll do it this way.
Actually,
leave it.
that's
Nice.
pretty good.
Yeah, I think we just balloon
Yeah,
it, right?
just balloon it, right?
Yeah.
So now tell us about the balloon sizing. There's another question because obviously in that area it's very compressed,
Yeah.
right? So balloon sizing wise, how do you choose? Do you start small, 12, 10,
No, I think if the stent is 16, I go with the 16.
1 to 1?
Yes.
16 millimeter balloon, please, from Dr. Love's room. He has a 1640 Optese balloon. No, OptoPro. OptoPro.
Yeah, we tend to use the what is the Atlas Gold?
You do, huh?
Yeah.
See, so here, because to save costs, we share with Dr. Love.
Yeah, of course.
So we use the pediatric balloons that he uses for pediatric
So
valvuloplasty.
if you do the OptoPro, you have to be careful, especially with the wall stents. They tend to tear.
They do, huh?
They tear and then they can shear, which is
Wow.
another problem.
Okay,
Yeah.
so
Yeah.
see, you learn everything every day, right? So now we know we got to get the other
I
ones.
think Pablo's been called to remove one before from someone's popliteal.
Oh Lord!
Yeah,
So we
that's
just
true.
checked another ACT. We're at
376.
so we're at good ACT. Our ACT is anticoagulant. Now let's talk about management of the sheets. You have a 18 French on the right groin, 10 French on the left. 10 obviously is going to be pretty easy to manage. How do you manage the 18? Do you per-close the vein? Do you guys use a closure device or just good old manual pressure?
Purse string.
Purse string. Oh, you do purse strings.
Yeah,
Okay.
just purse
Yourself?
Or hold pressure.
A good old fellow manual person.
Good old fellow. And then
For the neck, for sure, we just hold pressure. I'm not purse stringing.
Yeah,
someone's-
of course. All right. So okay.
For venous procedure.
And
right?
do you guys reverse the anticoagulation is the question. Right now the ACT is quite high. So you have the Atlas? Vita. That's fine.
That's fine.
Yeah.
That's even more expensive, but
Yeah, that's why I tried to avoid it. So, there's a shortage of balloons, as you guys know. We're not able to get everything we used to have.
Yeah, I mean, there aren't a lot of options in terms of once you get above 12, right?
Yep.
Unless the ACT is over 300, I tend to not to reverse these patients.
Yeah.
Just
Pablo,
because he's also going to get an iliac vein stent, and we don't really want to reverse it at this time.
So what level? That's a great question. What level of ACT do you pull it? Do you feel comfortable pulling?
Well, definitely anywhere between definitely less than 200, less than around 100 should be.
So you wait until she drops and then you pull it.
Yeah, I don't think. What was the last ACT?
3 something, I believe.
Oh, 350.
350.
A little higher?
Oh, 376.
Right there. Perfect.
Yeah.
Well, actually, you got to go.
Yeah, that's a little bit high.
Yeah. That's why I was asking.
And that's a little bit high. I mean,
Yeah, like usually
Use the syringe?
50
Oh,
to 75. Like I'm okay with as long as it's coming down.
yeah, it's coming down, and we can give 20 to 40 of Promin to bring it down a little bit. If you guys are okay with that.
Yeah,
I think by the time
that's what I was going to do. I was going to give you Protamine.
Yeah,
Ready? Go up.
I think we should
up.
bring it down a little bit.
Oh, sorry, I did the wrong one. I did the
Oh, that's
Stenting.
okay. So I'm just injecting here,
take it
just
again?
going up
Sorry.
slowly. Tell me when, guys. You're happy there?
I mean,
So, Dr. Krishna, are you
You
okay
good
with
there?
40 of Promin?
Yeah,
Sure.
that's good.
Can we have 40 of Promin, please?
Down?
Yeah.
Okay. So again, I just was always good to talk to one another. So obviously, I asked Dr. Patel, how do you gauge the balloon? I guess you go by profile, Rahul. And
Yeah,
the
we usually
profile-
use the.
Yep. Oh, you use endoflator.
Yeah, yeah.
Okay.
My fellows aren't as strong as you.
Oh, if Pablo did this, it'll be the size of the IVC. I'm ready going to go up gently here.
The
So
interesting
again-
thing on you guys' CT Venogram is that you can see there's collaterals around the groin. So I think that common femoral vein external.
Tell me when, guys.
Problem.
You gotta take it up.
Okay. Just
Yeah,
wanna make
that's a very important point to note what Srini told about. Is that gauging the collateral,
yeah.
but you're right, because the disease extends further down.
a little more.
And eventually you have to come back and try to expand on the SV
Okay.
V part of the vein as well to really have a good inflow coming in. So yeah, that makes very good sense. That's very good.
Let's come down.
So yeah, usually, so Srini, how often do you per close versus manual this in your
That's what I was
practice?
going to ask you guys. Yeah. Because per close in the veins has become very common now, guys.
Yes.
A lot of people are
come down
doing
a
it,
little more.
especially. Oh, sorry.
I per close all my
Especially EP
veins.
Guys.
There you go.
Especially the EP guys are per closing, and I know Vishal is very aggressive with per close. And any thoughts on that, Pablo, as a surgeon, per close in the vein?
I mean,
Oh, that she felt that.
Yeah.
I don't know any of the data behind that.
There is none.
There is none.
There's no data.
It is a pretty it's a pretty big needle that puts a stitch, and the veins tend not to be that.
Good. Come back a little
Sometimes
more.
they can tend to be friable.
Here we can
So
just do
I have
gently,
no
I guess.
Yeah,
experience
I'll do
really
gentle.
to comment on that. I
me
like
when
to
you
hold
stop.
pressure on them because we do surgeries, and quite frankly, we hold pressure on a lot of
feel it
venous
popping.
structure that bleed,
Yeah.
and after a good pressure, they always
Keep going,
stop.
keep going.
So I tend to use the old conservative method.
That's pretty good.
That's good.
Yeah, it looks good. Expanded.
Yeah, we're just trying to be very gentle and obviously could not get into any issues with the vein.
A good rule of thumb is, people consider common iliac vein around 16, external around 14, common femoral vein around 12
Yeah.
or more.
Okay, ready?
Some people
DSA
use
bite?
area.
Yep.
Yep. Okay, Cindy.
Wow, oh, fantastic!
Nice.
Is that something to worry about there?
Nah.
Okay, good.
Looks good.
Yeah, looks great.
Beautiful.
Just we'll do a quick IVUS and then we'll be done. So and then how do you guys always post IVUS? That's another question I often get. We tend to always post IVUS.
We do. We
just
have
to
you
make
have
sure.
it there.
So they always ask this question, Rahul and Pablo and Srini. What are you looking for post IVUS? Are you looking for poor stent expansion? Are you looking for compression of the stent? What are the things you guys are looking for post IVUS?
Really, just some pinch points, right? So if it's poor expansion in areas, especially bad
Got it.
May thinner lesions, you may not. It looks good, but it's just pancaked.
Uh-huh.
You can't really tell on a 2D image,
Right. Good.
Yeah,
Here's-
and for me, it's make sure that we have
Oh, you want to
land the stain
Nice.
correctly, proximal and distally,
There you go.
more so
right,
in
let's
the
record
inflow,
above
make
below.
sure there's
Yep.
no stenotic
All right, we're going to
lesion.
record above below, guys. Record. So let's see. I'm coming real slow here. Perfect. Look at that. Look at that
Yeah,
for everybody at
very
home.
nice.
That's just unbelievable what Rahul did. That's awesome. And look at the nice expansion. Do you guys look for infolding? Because sometimes you see the struts infolded, and that's when we tend to post-dilate it again. But here it looks pretty good. Stent looks really good. And then the distal is actually not so well. Now we're in the sheet. Yeah, we're in the sheet now. So we're going to have to do what Dr. Patel said is probably go back in and do it. Would you do it in this setting? Would you wait to see how she does? How do you guys just want to do that?
I would say wait.
Yeah, the flow looks so much better. She might be enough.
It looked pretty good. I understand the IVUS didn't look that great, but certainly it looked a lot better than what we saw.
And without the compression, it should get better.
And see how the symptoms.
So I guess if Srini, any last comments before we sign off? And we want to be on time. We're a little bit late. But any last comments, Srini?
No, I think, real quick, I think the way to think about it is that, look, she did not thrombose with that common femoral vein and that external being that tight and that narrowed with all the metal she had in there. So I think there's nothing wrong with just waiting. Right.
Got it. Well, Rahul, any final thoughts? Any tips that you want to leave them
I think
with?
One thing also is, again, like we said, we're going to wait on the common femoral. I think once my fellows or new people get stuck is they're trying to make it look perfect, and like because treat it like an artery, like it has to look perfect. And here, I don't think it needs to look perfect. I think if you try to chase perfect, you end up in trouble, right?
Right.
And so here, she's got good outflow. We're not going to make her leg 100% back to normal, but if we can get her symptoms down 50, 60%, I think she'll be very, very happy.
That'll be fantastic.
Yeah.
Pablo, any final thoughts?
No, I thought it was a great case. It was a good collaboration between different departments in the hospital. The approach from below and top, really, I think that was the key for this case. And I thought it was a great case.
Well, thank you. Well, listen, I want to thank everybody. I want to thank, obviously, Dr. Tamala. I know you're an NCVH. You have a lecture later. So thank you so much for making time. Make sure to give Dr. Matasari a hard time for blowing Rahul off and me off and Kumar off, and Pablo off. But no, really, all jokes aside, thank you very much. And on top of that, my two colleagues here are good friends and really just so incredible in terms of teaching how the proper way of doing it, discussing the pitfalls, the complications, and also the right way of approaching this particular disease. Obviously, the indication in all of our opinions was probably a little bit softish because of the fact that this filter hadn't thrombosed. But I think with a young lady who's 50-something years old, long time to go, like Dr. Kim said, anticoagulation is not without its side effects. So you do have to think about these things. So with that being said, I want to thank all of you, and we're going to sign off here with Vishal, and we'll see everyone next month for another great live case. Just a little plug about NYEVS. We'll be doing NYEVS. Obviously, Dr. Tamala, Dr. Patel, Dr. Kim, myself, and Vishal will all be there. And, we have a lot of interesting cases. We have live cases from Leipzig with Dirk and Andre doing live cases, Chris Metzger doing live cases, Steve Hanau doing live cases, and obviously ourselves as well, and Fadi Saab and Jihad Mustafa. So we have live cases from all over. On top of IR, is going to do some great venous cases from down below, and Dr. Kim and his colleagues are going to run the aortic, symposium, especially with cadaver labs, with a tremendous amount of teaching, case presentations. For the fellows, there's a fellows case competition for venous, arterial, and aortic, and where we give out great prizes. So obviously it's a limited number. We have 60 fellows for both the venous and our side combined. So, and then we have another 30 for the aortic side. So 90 fellows. Last year we sold out within a month and a half. So please, if you're really interested, go ahead and get involved and come join us in New York. So thank you again, guys. Thank you.
Thank you.
Thanks, guys.
Thank you.
All right. Thank you.